in charge of acute care reimbursement for Baker Tilly. What we're going to talk to you about today is the 2025 proposed rule for inpatient hospital services. I have with me Brian Restivo, who's a director in our acute care reimbursement group. And if you don't know already and haven't heard Brian and I talk, Brian will be doing the heavy lifting on a lot of the technical areas. With that, we'll kind of get started. I'm going to kick it off with the next slide. Some of our key objectives, like I said, are to go over the 2025 proposed rule for inpatient prospective payment. We want to cover a lot of different areas in here, but some of the bigger areas are like the wage index. And one of the newer areas we'll cover this time is some of the new labor areas, MSAs from the OMB that CMS has decided to adopt in 2025. So if we kick it off to the agenda, specifically, we're going to cover obviously the overall impact, but we'll cover uncompensated care portion of DISH and what's proposed there. There's some new technology add-on payment changes that we'll cover. There's a new proposed rule on Medicare buffer stock for medications. We'll cover IME, GME proposed rule changes. We will cover wage index because there's a lot going on there continuing. The labor market, as I said, and we have some other miscellaneous updates that we'll cover for you. So with that, we'll go to the next slide. This just is telling you what we're getting into. Okay, the proposed rule, most of you probably know now, Medicare's been published a lot of comments out there on it. They're doing a 2.6% proposed rule, which is the equivalent of about 2.9 billion, which doesn't mean much to you individually. That's system-wide. The American Hospital Association has basically said that this increase is woefully inadequate. I believe it was a quote from someone there. The MedPAC, who puts out a report to Congress in March each year, put one out again in 24 here, and they indicated they felt a 4.1% increase was needed, which is a difference of about 1.5%, which is a lot of money. So last year in 24, they also recommended a higher percentage, and in the final rule, it did come out higher. So that thinking positively, we'll hope that that comes out in the final rule, but your comments could help. So make sure you get your comments out there. I believe the date's June 10th to get your comments in. So make sure that you participate. Next slide. How did we get to the 2.6%? Well, started out at 3%, which you'll see 25 down there. That's the market basket increase. Then they took out 0.4% for productivity adjustments, no coding or documentation adjustment in the current year. So they ended at 2.6. In this 4-year display, you can see that 2.6 would be the lowest of the last 3 years, which were 4.3% and 3.1, and only 0.1% higher than 22. And I believe that that shows that this year is down, and we'll cover some things today that indicate that cost is much higher. So let's go to the next slide, which covers the budget neutrality adjustments for this year. You can see the adjustments for the DRG reclass and recalibration, the capital policy, wage index budget neutrality. The reclassification budget neutrality factor is the biggest there at 0.976773. That's a pretty big adjustment. Remembering that the rural floor budget neutrality factor is actually adjusted against wage index, which Brian will talk about later. It's not adjusted into the standardized amount. Then you've got some of the newer policies of the low wage index adjustment, the capital policy budget neutrality adjustment, and rural demonstration. All of those factors are below 1, so they all go to reduce what the standardized amount starts out at. Speaking of which, in the next slide, we show you just a comparison as what this is. That shows you 2024 final to 2025 proposed, and you can see that the labor related, which is adjusted by your own wage amount, went up a little over, let's say, about $103. The non-labor went up about 63 or so. So not a whole lot of dollar increase when it's only 2.6%. Capital, which I believe went up 4.5% last year in 24, increased 2.5% this year, for about a $13 increase, so down some over the increase from the previous year. Next slide, please. So what has gone up? Well, the outlier threshold has gone up, and as CMS, if you read the proposed rule, they make this equivalent to, in their calculations, to 5.1%. So in order to get that, they have to increase the fixed loss threshold each year. Otherwise, it would go over that percentage. So in 22 to 23, the change went from 30,998 to 38,859. That's a 25% increase. In 23 to 24, a more reasonable increase from 4.8%. So, and now in 24 to 25, the proposed jumps from 40,732 up to 49,237. That's a 20.9% increase. So over a 3-year period, that increase has gone up around 50%. I think this is a good example of how much costs have gone up because of what CMS has had to do to keep the outlier at the 5.1% threshold. Which leads us to a polling question, and we have asked this pretty consistently over the last year or so in relating to what CMS is increasing of 2.6% and related to what you believe your cost will increase going forward and projecting into 2025. Is it down around that increase of 2.5% or so? Little more, higher, between 4.5 to 8? You don't know, or it's not applicable to your position. So while you answer that, and remember you need to answer it to get CPE, we will move on to the next section, which is Medicare DSH, or in this instance, really uncompensated care. Let's go to the next slide. So where were we today? Well, in 2025, we will be using the audited S10s from 2019, 20, and 21 S10 reports. So that is what the data will be using for the allocation of the pool. One thing I always like to stress here is keep in mind, because there's a lot of mergers and acquisitions, keep in mind that if you have merged a hospital into your hospital, meaning their provider number no longer exists and they take your provider number, there is a settlement in the year that you take over that hospital, but it has to wait until the cost reports settle. And then you would add their S10 data into your S10 data and calculate the final settlement. So keep that in mind. That is not lost in that year. It's just that it won't happen until settlement. Next slide. So what do you get paid going into 25 is going to be based on what we just talked about as far as dollar amount, but the discharges used are going to be the average of the 21, 22, and 23 years, 3-year average. So a thing to keep in mind here on your payment is that when you, let's say you had 5,000 discharges in your 3-year average and you get paid $2.5 million. If discharges in your cost report year only come out to 4,500 from Medicare, then you didn't receive that 500 additional discharges worth of uncompensated care money, so you'll get that on your cost report settlement. If you go over and had 5,500 discharges in this example, you would be overpaid and you would have to pay back what you received for those 500 discharges over the 5,000. So there is a settlement on it, even though you get paid a flat amount. So just want everyone to keep that in mind. So when we take a look at what they did for the year, it's a $560 million proposed increase coming off of last year's $936 million decrease, which started out in the proposed rule, I believe, around $161 million decrease. So it's been sort of a seesaw. There are just under 2,400 hospitals that receive uncompensated care in the 2025 table. So on the average, on a strict average, that would mean the 560 million would mean another 230 million, 230,000 per hospital increase on the average. Obviously, we know there'll be big winners and losers, but that's just the average to take into account. And then in the next slide, we just kind of outlined what happened last year. 161 million was proposed, 936 million final. That's a change, huge change, 774 million. This year, $560 million proposed, and we are very much hoping that doesn't change to the negative in the final rule. New technology. So the new technology, the numbers, impact numbers from CMS are that is projected to be a $94 million increase for 25. There are 26 new applications, 12 under traditional pathway, and 14 under alternative. There's going to be 24 that are still considered in the new and will be continued, and 7 that will drop off because they're no longer considered new technology. Next slide. Next slide, please. Oh, sorry, I think that went 2. Yes, thank you. Okay, so speaking of newness, they are going to define newness, and they want to change the date from April 1st to October 1st to more line with the federal fiscal year. And they want to take the 25 approvals and begin payment in 26. CMS is soliciting comments on this. So if you believe this negatively impacts you, we would recommend that you submit a comment. In the next slide, they're going in and defining that any application that has a hold status that they want to make inactive, and any applications withdrawn or subject to an FDA decision, they would consider them for eligibility. This policy will be reassessed ongoing. So I think comments on this would be well pointed. The next item, which to me is one of the more important ones, is the on the next slide, is the gene therapy, where they're raising the new technology add-on payment from 65 to 75% because they consider sickle cell disease to be one of the more costly treatments. They want to increase the payment there, and according to CMS, they're doing this not only to reduce costs, but hopefully improve health outcomes through new technology. The next polling question to see if you're awake is, do you currently receive payments from new technology add-on payments? Answers are yes, no. We're critical access and not eligible, I don't know, or not applicable. The next item is the new proposal on buffer stock, which is not stock market, it's inventory of the essential meds. And what they want to do is start this on October 1st of 24, but it's not for the drug itself, it's for the additional resources of maintaining the buffer stock. And it could be provided in a lump sum or pass through. And it's not budget neutral. So who does, in the next slide here, who does this impact? Well, you got to have less than 100 beds, and you have to be independent, so not part of a chain. And CMS has estimated that that's 493 hospitals. And that these smaller hospitals obviously lack the resources so that this will benefit them. And CMS has estimated what this would be on their portion, $300,000 for Medicare. In the next slide, it kind of tells you what wouldn't be in there. So if a drug is currently in shortage by the FDA, that wouldn't be included. And if the hospital cannot do this on their own, like they don't have space or staff, then they would be able to contract with a pharmacy manufacturer, supplier, to maintain this buffer stock. So there are some options there for the small hospitals that can't do that on their own. So there, the answer, let's see, we've gotten answers before we move on. The answer to the first polling question, shows, I can't see that very well, I'm sorry to say. Oh, I'm sorry, the increase. The majority of you answered that in column or line 2 or 3, which would be in the 2.5 roughly to 4.5 increase, or 4.5 to 8% increase. So probably above what CMS is going to give you. So at this point, I will turn it over to Brian to talk about wage index.
Thank you, Keith. So I'm going to start here on my portion of the presentation and start going through the wage index updates for federal fiscal year 2025. All these changes here that I'm going to be talking about will be effective on October 1st of this year for inpatient services to Medicare patients. And for outpatient, it would be effective on January 1st when the outpatient goes into effect. Again, when you look at the wage index updates, as well as the other updates that Keith spoke about in terms of rate changes, these changes also flow through to your Medicare Advantage or Medicare HMO contract prices as well. So this does not only affect your traditional Medicare population, but your Medicare managed care. So keep that in the back of your mind when we talk through some of these comments on the changes here. The big change that's happening here that I'll go into a little bit more detail in a couple of slides is that CMS is updating the CBSA maps for wage index purposes starting in 2025. They typically do this every 10 years or so when the census has been updated. There's about a 5-year lag between the U.S. Census and when the OMB updates their delineations or what we consider CBSAs for wage index purposes. Through this process, there's a lot of changes geographically where hospitals are classified as that we'll get into. But before that, the 2025 wage index will use federal fiscal year 2021 cost report data. And what that means is if you're a 9/30 or 12/31 year-end hospital, that's your 2021 fiscal year. Or if you're 6/30 or 3/31, that would be your 2022 fiscal year data. So keep that in your mind as you go forward, that there's a large lag between your incurred salary costs and what CMS uses moving forward. So it's about a 3-year lag between those items. The other big update for 2025 is that CMS will be using the 2022 occupational mix data. If you remember, that was due over the summer last year. This will be updated and used for the next 3 years. And we'll talk a little bit more about that in a couple slides, but about 96% of the hospitals submitted the occupational mix data. The 4% that did not submit will actually use the CBSA average for their particular occupational mix adjustment. CMS continues to require that hospitals submit the occupational mix data, but that does not have a penalty to do so. We do recommend following that survey so you can ensure that your wage index is not harmed by not submitting it. Each year, CMS puts out the data. They exclude hospitals' data for either non-compliance at audit or that their increases were unsubstantiated through the audit process. Sometimes these hospitals don't even realize that their data has been excluded from the wage index calculations. It's happened last year to a few folks that didn't realize it. So it's very critical that as you go through the wage index timeline and process that you're checking in on your data on each step of the process. Just because of data transmission errors between the Medicare auditors and CMS, there's a lot lost and commingled with the data that ends up in erroneous errors. And once they're set, it's hard to get overturned. So we'll talk a little bit more about that process later on. What we're seeing, though, is about an 8.7% increase on the national average wage for federal fiscal year 25 versus 2024. As you see along the chart on the bottom there's a large increase starting in 2024 that's increased even more here for 25, and that's related predominantly due to the fallout from the COVID-19 pandemic with the increase of contracted labor, increase in nursing salaries and benefits. So this is now kind of, we're in full swing here of the impact of the pandemic and the impact to salaries and benefits included in the wage index. Because typically we see anywhere between 2.5% to 3% on any given year, but now we're approaching 8.7% increase. And at a macro level, the way the wage index works is if your hospital is not increasing 8.7% or more, your wage index will go down, and vice versa. So if you're not keeping up with that national average in your market, you'll have a decrease in payments. If your salaries are above that, you'll get an increase. And the wage index is budget neutral overall. So overall, there's winners and losers that'll net to zero. So keep that in mind, that you've got to make sure that your data is clean as can be, just so that you don't have a decrease for bad data. Part of the wage index is the challenges in understanding what you're getting paid has to do with reclassifications. So about 1,100 hospitals, or 35% of the hospitals overall, have a wage index reclassification in place for 2025. There's many hospitals that don't qualify for reclassifications for various reasons, but it's still only less than half have one in place. Again, we recommend looking at this every year. We see hospitals that they get to apply in September. We see hospitals that are reclassed into a place that's no longer beneficial to them. So even though the reclasses are good for 3 years, the actual impact may change year over year. So I'm going to move on to the next slide here and talk a little bit more about the actual revised labor markets. And this is what we call CBSAs. Some cases that CMS has just changed the name or the actual CBSA number of the market that you would be in. So in those cases, there's really no impact. And we have some of the tables that if you need, you can reach out to us. But in other cases, the CBSA is consuming or taking over a whole nother CBSA. So in those cases, your wage index could be totally different in 2025 versus the prior year. Again, there's going to be winners and losers on all these changes with the new markets. But to keep in mind that you're held harmless for any reduction up to a 5% cap, and that 5% cap's been in place for a couple of years now. So if your wage index would have been projected to go down 10% for any change, including these new market, you'll actually get capped at a 5% decrease. But what will happen is year over year is that eventually that full impact will come through, if you're year over year. So it's important to keep an eye on where you are and how this new change may impact your hospital or hospitals. 5% of the wage index could be a material amount to your Medicare rates. For inpatient purposes, 62% of your rate is adjusted for the wage index. And on the outpatient side, 60% of it is adjusted for the wage index. So it's important to make sure that you're modeling that for your budget purposes or for your AR models of what payment rate changes may be out there. The other thing that will happen as part of these new markets is some hospitals will now qualify for certain rural grants that they previously were not able to qualify for. So it's important that not just for wage index purposes is to go out to the federal grants websites and see what grants may be available to your hospital now that if you're considered rural. So we're going to do a little bit of a background here on some of the definitions in terms of what CMS uses as urban versus rural, but it's a common question that comes up. But the short end of it is that if there's a population of less than 50,000, it's considered a micropolitan area, or what we would consider rural areas for Medicare purposes. Metropolitan areas would be your urban areas, which is either a county or a group of counties that are mapped that have a population of at least 2.5 million. So there's all sorts of subdivisions from state into these groups and then into counties. So there are maps that are posted by the OMB, which is Office of Management and Budget, that will outline where your county is. And if you ever need, you can reach out to either myself or Keith, and we can make sure that you get the link to that map, so you can see where you are. But CMS does publish whether your hospital is considered rural or urban in each proposed and final rule. So you could easily also go to the tables that Medicare publishes. We're going to move on to the next slide here. So there's a couple of different impacts here because of these changes. There's going to be about 5 more CBSAs in 2025 versus 2024. There's going to be about 54 counties and 24 hospitals that were located in rural areas previously that are now going to be considered urban hospitals. So not in that 24 hospital list could be some critical access hospitals. If you were located in any of those counties that were previously rural that are now urban, you have to submit a reclassification to go from urban back to rural within 2 years of the final rule. And this is very important because if you don't submit that application for the reclass, you would lose your critical access hospital status, which could be detrimental to your facility. So it's very important, again, to check what changes this may impact. The other hospitals that may be impacted by this, if you were previously rural and now urban, is any Medicare dependent hospital or sole community hospital status could be impacted by the change as well. So again, there may be a need to reclassify from urban to rural to make sure that you keep your Medicare dependent or sole community hospital status. Unfortunately, with these two hospitals, there is no grace period like a critical access hospital. So you would have to submit an application prior to 10/1/2024 to ensure that you kept your Medicare dependent or sole community hospital status if you were, in fact, impacted by the new delineations that were put out there. So again, I recommend everybody to go check their hospital statuses and see what type of hospital they are and whether or not they're impacted by the new CBSA changes. What you also have going on besides rural hospitals becoming urban is urban hospitals moving to a new CBSA, and that could impact your reclassifications that you may have in place. It could impact your historical wage index. What you used to get paid could be significantly different than it was in prior years. So again, that's just another item. Just because you're not rural and flipping around, if you're an urban hospital, you need to check to see where your new location is to see what the impact is. We'll continue moving on to some more impacts here. There's about 53 counties or 33 hospitals that were now urban that'll become rural. Historically, in the past, the last time this happened, 2015, CMS gave a 3-year transition period for any impact to the wage index. That is now off the table. Medicare is relying on the 5% wage index cap instead of implementing a transition period. So again, these urban hospitals are at risk for a potential decline in their wage index of up to 5%. There is also some implications for these potential hospitals that could be a benefit if they're teaching hospitals, and we'll talk about that in a little bit. 17 of those counties would become Lugar counties, which I'll talk about here in a little bit. So that would essentially keep hospitals that are rural to be paid at the urban wage index rate. The other thing these hospitals need to keep in mind is that their dish payments would now be impacted as well. There's different rules for rural hospitals versus urban hospitals when it comes to Medicare dish payments, depending on the bed size. So there is a phased down reduction in dish payments for any of those impacted hospitals. So CMS will phase in that reduction in payments over 3 years. But your hospital could have a negative impact on Medicare dish payments as well. So it's important to get a good understanding of what your financial implications are for these new changes just from the new maps that CMS put out based on the updated census. Next up, I'm going to talk a little bit about the Lugar County status and what that means. We can move on to the next slide, please. So Lugar counties are considered geographically rural areas, but also have a high number of residents that commute to another CBSA for work. Essentially, they're either surrounded by urban counties on all four sides, or there's a large metropolitan city in an adjacent county. In these cases, CMS recognizes that most of the workers are commuting to elsewhere to work, and the wages may not be reflective. In this case, what Medicare does is assign that hospital or group of hospitals in that county the urban wage index in which the population commutes to. There is the ability to waive this status that has implications on how you're treated for all other purposes. But again, it's got to be a full financial analysis of whether or not the Lugar County status from a wage index perspective is more beneficial to you. You have 45 days from the proposed rule being put out to make this cancellation if you wanted to waive the Lugar hospital status. But once you do, you would be treated as a rural hospital instead of having the urban designation for wage index. So again, there's a large calculation that needs to be done here in a short 45-day window. Typically, hospitals are well aware whether or not they're Lugar County status or not each year. But when you have a new MAPS and CBSA groups growing up for the first time in 10 years, some hospitals may not be aware of that they are now in a Lugar County. So it definitely needs to be looked at for your hospitals if this impacts you. Moving on the wage index topic on the next slide. We're going to talk about how these new MAPs and CBSAs change reclassifications. So there's a lot of nuances when it comes to wage index reclassifications, and this just kind of further complicates the topic even more. So any hospital that's impacted by the new delineation should review their current wage index reclassification for multiple reasons. One, it may be beneficial to withdraw from the reclass you had in place. If any area around you that you could reclassify to was impacted by this new change, there may be an opportunity for you to submit a request to CMS now to reclassify. Again, this is outside the normal rules when it comes to wage index reclasses. But again, you've got to take a look at not just your market, but what's around you to see if there's now a better place to go because of this new MAPs. And again, you'll have a certain time frame to submit an application to CMS if you think that there's a better area for you. Any urban counties becoming rural, if you had an existing reclass in place to your home CBSA, that will stay intact. If you were a hospital that had a reclass in an urban area that became rural, that particular reclass would be terminated. So again, you got to make sure that you're looking at where you were classified for. For hospitals that were reclassed to a CBSA that no longer exists or went to a different CBSA, CMS is going to determine the best location for you unless you submit otherwise. So again, it's important to take a look at what scenarios are out there. Again, if CMS is proposing an alternate location, you want to make sure that that is actually the best opportunity for you and there's nothing else out there. Moving along on this topic. Oops. All right, so again, the other thing that happens here is under federal regulations, if you're a hospital that has multiple campuses, and Keith spoke about it previously, where you have sometimes mergers of certain provider numbers into an existing medical provider agreement. Current regulations state that if your remote location is in a different CBSA from your main campus, there are certain requirements from an enrollment standpoint that campus has to be separately identified and paid its own wage index of where it's located. In those scenarios where you have a campus that's located in different CBSA than your main hospital, you could actually have two separate reclassifications into different areas, whether it's the main campus or the remote location. Any hospitals that were previously multiple campuses that had different CBSAs would have any reclass canceled if it does become part of the main hospital's campus, the CBSA. Likewise, you may now have campuses that are located in a different CBSA than your main hospital, which would require you to update CMS's enrollment and reach out to the MAC to make sure you get a special provider number established. So if you are a hospital that operates multiple campuses for inpatient services under one provider number, you need to make sure that not only did the main hospital did not change, but none of the campuses were impacted by the new CBSA updates as well, because there could be some risks or lost revenue on the table if that is missed. Again, the deadline to submit to CMS for any changes of reclassifications you may want to make, just they're due by May 24th, so next week. And I want to be clear that these reclassification requests are only if you're impacted by the new OMB delineation. So if your hospital or your labor market or surrounding area was not impacted by the OMB, you do not have the opportunity to change what reclass was in place. So it's a very confusing topic. So if you have any questions, feel free to reach out to one of us here and we can kind of help you decide whether or not you would have the eligibility to submit something to PMS. But again, that time is next week. So we want to make sure that that's on your radar to at least look at to see if you qualify. The other thing in regards to wage index that's out there is the continuation of the low wage index policy. This has been out there since 2020, and last year was extended for one additional year. And this year's proposed rule, they're proposing for 3 more years that the low wage index policy would continue, at least through what they call to get far enough away from the COVID pandemic. On the next slide, I'll talk about a little bit about what that means essentially. But if you move to the next slide, what this means is that those hospitals with the wage index below the 25th percentile actually get an increase up in the calculation. And since this is budget neutral, there are hospitals that lose from this policy. And there's been litigation on this topic for going back and forth now for quite some time. And CMS has appealed that decision to the district court. And CMS has said that it will not change its stance until the court decides ultimately if CMS can continue this or not. But essentially, there would be an adjustment for those in the 25th percentile. And again, negatively impacts those that are not in the 25th percentile. So I'd just like to move along here, just briefly on the rural floor. The big change was last year, and I won't go into too much details there, considering the time we're at here. But there's 492 hospitals that are projected to receive the rural floor in 2025. That's a slight increase over the prior, slight decline over the prior year. And all new hospitals from the new OMB delineation is going to be included in this year's rural floor calculation. So the rural floor is definitely a little bit shooken up over the last 2 years, but that will continue. There's no changes there in how CMS is treating those particular hospitals. And just a reminder on the next slide, typically Medicare used to give you 45 days from the publishing of the proposed rule to terminate or withdraw from any wage index reclass. That's actually changed to 45 days from the public display copy, which so keep that in mind, please. Is that the new deadline date? What I'm going to talk about next is the occupational mix survey. So the way the occupational mix works is that it's used to adjust the wage index factor for hospital staffing decisions and salaries for nursing staff. Essentially what happens is the hours in each nursing category that we have up here on the screen is multiplied by the national average wage for that particular category. All those nursing salaries get aggregated. So you see the $50.17 there. That's the national average for the nursing categories across the country. And you can see this stark increase from 2019 survey, predominantly due to the COVID-19 pandemic and contract labor. But the thing to keep in mind is that if your hospital is above the $50.17, you'll actually get a reduction in your wage index. If you're below the 50.17, you'll get an increase to your wage index for the occupational mix. So again, this is important data to make sure that you get correct when you submit the survey, but there are certain opportunities here that if you notice something was wrong, that you can request a change during the next audit period over the fall with your wage index review. And I'm going to walk through here. The next quickly is the wage index review process here over the next, the wage index review process lasts about 15 months. So as I mentioned before, it's important to check your data at each point of these steps for any errors that you may see or any audit disputes. Everything's going to be followed by certain timelines, and any miss of those deadlines could lead to some harm down the road that can't be corrected in that fiscal year. So on the next slide, and you'll get a copy of the slide deck, I won't go through each line here, but this is essentially the process deadlines here that you need to keep in mind when you're thinking about wage index and data moving forward. So next topic, I'm going to do a polling question here. For the third polling question is, was your hospital impacted by the new OMB delineations? Yes. No, I'm not sure. It's not applicable. So again, remember that even though you're not a hospital, you may have a long-term care or other type of healthcare facility that has a wage-adjusted factor that could be impacted. Next, I'm going to talk a little bit about medical education changes that are in the proposed rule, and there are some clarifying items here. The big thing is those hospitals that are a change from urban to rural or rural to urban from the new OMB delineations. If you were previously a rural hospital that's now designated as urban, you will not lose the 30% cap increase that you previously were awarded as being a rural hospital. If you have a cap, if you're building new programs and building cap, or you have accreditation to start a new program, so you can continue to build that cap until the end of its 5-year building period. Again, the big piece is that the program had to be accredited prior to 10/1 of 2024. For those urban hospitals that are designated as rural, you'll actually get a 30% increase on your base year cap amount so long as you didn't get the 30% increase through a reclassification. But you would also be able to have the ability to adjust your IME, DGME caps moving forward for new programs. So again, move along to the next topic here. CMS has proposed to clarify, this is very important for teaching hospitals across the board, to clarify what they mean by new residency programs. There's 3 main criteria: new teaching staff, new program director, and that the program residents are new. And what CMS is doing here is clarifying what they mean by new in order to get new cap adjustments. So CMS is proposing that all residents need to be at least 90% of the residents need to have no training in the same specialty to be considered a new resident to get the new cap adjustment. So again, they have some nuances here that they're looking to have an exception for small rural hospitals for programs less than 16 residents, but this could impact large urban hospitals that are looking to build new programs and taking on residents from other facilities to do so. In addition, on the next slide, I'll talk about they're looking for comments on similar when they determine whether a program director or faculty are new. They're looking at there should be a set defined period of time in which a program director or faculty cannot be in that position. So that kind of limits hiring program directors for a new program. So again, they're seeking comments here and they're calling it suggestion. So it's very important if you're a teaching hospital that you go through some of these new criteria to determine what you have on the docket to grow and establish, to make sure that those programs are considered new for your cap build adjustments. Again, some of this stuff is pretty subjective, that they won't allow a program director to be considered new if they were previously a program director 5 years ago at somewhere else. So again, it could be limiting what you guys may be able to get as a new program adjustment moving forward. The other issue is important for urban and rural reclassified hospitals that CMS is seeking comments on 2 issues. Again, we want to make sure that you guys are aware of submitting comments and questions. Is that CMS wants to determine, clarify how they handle cap build adjustments for urban and rural hospitals when there's residents rotating from new program to your hospital and vice versa in the same specialty. So moving along, there's 2 here, 2 hospitals that are closing here, in which there'll be an application process for applying for cap slots. One is in the Toledo, Ohio area, and the other is in the St. Louis, Missouri area. Applications are due on July 9th for these cap slots to become permanent. Any questions, you can reach out to Keith or I, and we can help you walk through what requirements are there for the application process. In addition to that, CMS is funding another 200 GME positions, similar to the prior years where they had the expansion of 1,000 residents. They're adding 200 more resident positions. Again, this will act similar to the Section 126 expansion, the same rules, same qualifications in order to get these cap slots. There are some nuances here on the next page that is slightly different. Is that half the positions need to be psychiatry programs or subspecialty psych programs. And no hospital may receive more than 10 positions on that. So applications would be due March 31st on that there. And that handles most of that. So I'll walk through the other proposed changes here that you need to be aware of. Most of these here are going to be legislative changes with the low volume payments. So right now, that criteria is expiring on December 31st of 2024. This has been historically renewed by Congress every year, but there's been a lag and delay when this is done. So there's lots of deadlines to keep in mind here, whether you want to make sure that you're submitting by 9/1 of 2024 to renew your low volume adjustment for the period of October through December. It's important to get that in too, because that typically carries over to the next year if they do get renewed. But again, it's an important deadline that you don't want to miss if you get low volume payments. And again, CMS needs congressional action for that to get approved. Similar to low volume Medicare dependent hospital program is expiring in 2024 in December. Like low volume, this has been renewed historically, but a lot of times it expires and is renewed retroactively. It does impact about 173 hospitals across the country. Hospitals that are Medicare dependent can apply for sole community status if you're not already one, but we have to apply by December 2, 2024 to make sure that they have no loss in their hospital-specific payments. Again, most Medicare dependent are dually eligible, but here we have the rural referral center qualifications for those hospitals that are considering urban and rural reclass. The big change here is the case mix index that's posted here at the bottom. Again, that you should be able to get these slides here and see what that new CMI index is to see if you qualify to go from urban to rural. And we're going to try to finish up here with one last polling question for your CPE credits is, will your hospital lose either Medicare dependent hospital status or low volume payments if no congressional action is taken by December? A is yes, B no, our hospital does not qualify, I'm not sure, or not applicable. I'm gonna cruise into the finish line here with just a few minutes to spare. So I want to thank everybody for your time today. If you didn't get any questions in today, our contact information is up here, and you'll get a copy of the slide deck. Feel free to reach out to Keith and or I for any questions you may have. There's a lot of information here that we crammed into an hour of time. So just please reach out to us. Keith, I'm not sure if you have anything else to add in closing, but
No, we're kind of running low on time here. We appreciate everyone participating today, and look forward to maybe you all tuning in again when we go over the final rule later on this summer.
thank you, everybody.
Thank you.